This lecture will go over Chapter 43, The Child with the Gastrointestinal Alteration. Specifically, this recording will go over cleft lip and palate, esophageal atresia and tracheoesophageal fistula, and care of G-tube. Go ahead and review the A&P for the gastrointestinal system on your own if you're a little bit rusty on that. Please review at the beginning of the chapter the box that goes over the age-related differences in the pediatric gastrointestinal system. Those differences include infants have minimal saliva. Swallowing is not under voluntary control until 6 weeks. Infants and children have less stomach capacity. The stomach lies transversely and is horizontal in the infant's stomach. The abdomen is round in infants and toddlers. Peristaltic waves can reverse in infants, causing regurgitation and vomiting. In infants, peristalsis is faster and food remains in the stomach for a shorter period. Hydrochloric acid concentration is low until school age. Fever increases the rate of propulsion. The immature neonatal liver is not yet efficient in its detoxifying ability, resulting in less vitamin and mineral breakdown than in older children. The large intestine is relatively short, with less epithelial lining to absorb water from the fecal mass. As a result, stools have a soft consistency and peristalsis is more rapid. The GI system is formed in the first 4 weeks of embryonic development. The first disorder of prenatal development we'll talk about is cleft lip and palate. Cleft lip, cleft palate, and cleft lip and palate are separate anomalies that are closely related in etiology, pathophysiology, and nursing care. These distinct problems are all abnormal openings in the lip or palate. Cleft lip has the following manifestations: a notched vermilion border, variable sized clefts that involve the alveolar ridge, and dental anomalies. Cleft palate includes nasal distortion, midline or bilateral cleft with variable extensions from the uvula and soft and hard palates and exposed nasal cavities. The diagnosis of cleft lip and cleft palate is based on observation at birth and complete examination in the neonatal period. Diagnosis can also be made in utero with ultrasound. Cleft lip is readily diagnosed through inspection of the lip. The first sign of cleft palate may be milk or formula coming out of the nose. Management is based on the severity of the defect. The first intervention involves the modification of feeding techniques as needed to allow adequate growth. Use of special feeding techniques, obturators, and unique nipples and feeders can usually accomplish this goal and allow early discharge home with parents. These modified techniques can decrease the energy required for the infant to take in adequate nutrition. Before surgical repair, removable orthopedic devices may be used to expand and realign parts of the palate or decrease the size of a wide lip cleft. Cleft lip repair is usually performed by age 3 to 6 months. Early repair can improve bonding and makes feeding much easier. Some cosmetic modifications may be needed again at age 4 to 5 years. Cleft palate repair is individualized and based on the degree of deformity and the size of the child. Closure is completed between ages 6 and 24 months. Most teams recommend repair by 1 year of age. Earlier closure facilitates speech development. After surgery, the priority is to keep the suture line clean and intact, avoiding tension on the sutures. Children with cleft palate are at high risk for developing chronic otitis media, which can cause long-term hearing loss. Please review the purple patient-centered teaching box that reviews home care of the child with cleft lip or palate. It contains some important caregiver teaching tips. So when a patient or when a child is using special feeding methods to maximize growth while waiting for surgery, it is helpful to practice the feeding method to be used after surgery until the incision heals. The feeding method chosen will be based on what works for the child and what the physician recommends. Some tips that you may be teaching the caregivers include breastfeeding may be possible if the child has a small cleft lip or palate. A soft plastic compressible bottle will prevent your child from having to suck vigorously. because the breast milk and formula can be squeezed into the mouth if needed. There's an example of one of those bottles, if I can pull it up there. A longer nipple often allows the milk to be swallowed without entering the nose. It must not be so long that it causes gagging. Enlarging the nipple hole or cross-cutting a nipple can also be effective. A syringe with a rubber tip can also be used, especially after surgery. Feed the child slowly and provide short periods of rest for swallowing. Try to keep the child in an upright position during feedings to allow gravity to assist in the feeding and decrease the chance of choking. Burp the child frequently because excess air is often swallowed. Before surgical repair, devices might be placed in the child's mouth to help line up the cleft in the palate for better surgical repair or to decrease the size of the lip cleft. Some of these devices require special care and cleaning. After surgery, elbow restraints, also called no-nos, can be used so that the baby does not touch the stitches. Caregiver instructions include the following. Do not apply the restraints too tightly. They should be loose but still prevent elbow bending. Remove no-nos every 2 hours for 10 to 15 minutes and play games with the child to encourage movement of the elbows. Look for any skin irritation every time you move an elbow restraint. Remove only one elbow restraint at a time. Position the child for sleep on the back so stitches are not rubbing against linens. An infant seat can be used. Do not brush the child's teeth for 1 to 2 weeks after surgery. Feeding a small amount of water after meals will help to keep the teeth clean. Clean your child's lip as recommended by the physician. If ordered, you can use a cotton swab and a gentle rolling motion over the suture line and then apply antibiotic ointment in the same technique. Please review the Purple Nursing Care Plan for the child with cleft lip or palate on. Now we'll talk about esophageal atresia and tracheoesophageal fistula. So the first thing you need to know is the definition of atresia and fistula. So the first term we have here, esophageal atresia. Atresia is a condition in which a passage in the body is closed or absent. So in this case, the esophagus is coming down. Normally it's connected here, right? But it's closed off where it shouldn't be. So if the infant drinks some formula, it can come down to here and then this is closed. It can't go any further. So it puts the infant at risk for aspiration with that liquid refluxing back up and then going into the trachea. The next term you need to think about is fistula. What does fistula mean? Fistula is an abnormal connection. So with the tracheoesophageal fistula, it's telling you where that connection is, the trachea and the esophagus. So if there's a connection between the trachea and the esophagus, what might be the problem for my patient, right? The problem could be that stomach contents can come up and enter the trachea, or that air can come in and enter the stomach. Esophageal atresia and tracheoesophageal fistula are congenital malformations. Esophageal atresia is when the esophagus terminates before it reaches the stomach. Tracheoesophageal fistula occurs when a fistula is present that forms an unnatural connection between the esophagus and the trachea. Manifestations include failure to pass suction catheter or NG tube at birth, right? Because if the nurse were going to put in an NG tube, right, through the nose, then down the esophagus, it would bump against this abnormal closure. It wouldn't be able to thread down through into the stomach like it normally does. So failure to pass suction catheter, excessive oral secretions, coughing, choking, and respiratory distress. Normally those secretions can be swallowed down into the stomach, but right, they're not able to. They pool in this esophageal atresia, right? Because since it's closed there or stopped, so it pools and can flow back into the trachea. Vomiting, abdominal distension, right? If I have a fistula here, air can get into my stomach. And then airless scaphoid abdomen if the patient has atresia without a fistula. Atresia should be suspected if an NG tube cannot be passed 10 to 11 centimeters beyond the gum line. This suspicion is confirmed with an abdominal radiograph that will identify a proximal esophagus dilated with air, atresia, or abdominal distension with a fistula. Laryngotracheal bronchoscopy or endoscopy are also used to identify and assess fistulas and identify common secondary airway anomalies. In terms of therapeutic management, keeping the infant supine with the head of the bed elevated decreases the chances of gastric secretions entering the lungs. An NG2 must be in place and aspirated every 5 to 10 minutes to keep the proximal pouch clear of secretions and to avoid aspiration. Surgical repair is the mainstay of treatment. Initial repair includes ligation of the fistula and end-to-end anastomosis of the atresia to decrease the severity of stricture formation. So anastomosis is connecting two ends. So the surgical repair would be to connect the esophagus back together. Sometimes with the repair, the patient may need to have a G-tube placed. Please review the purple patient-centered teaching box regarding home care of the child with a gastrostomy tube. Also, review the purple nursing care box for the infant with tracheoesophageal fistula. And here's a slide also with that patient-centered teaching of home care of the child with a G-tube. You can pause the video and look at that.